The following feature presentation contains educational material dedicated to train the clinical staff at Optimus Healthcare. Vital signs. Vital signs provide important information related to the body's basic functions. If performed correctly, vital signs provide data to detect and manage medical problems. Blood pressure. Blood pressure is the force of blood pushing against the artery's walls as the heart pumps blood. Before the reading, perform hand hygiene. Greet and identify the patient and explain the procedure. Suggest the patients to empty their bladders before the blood pressure is taken. Ask the patient if within the past 30 minutes they have smoked cigarettes, exercise, drunk coffee or alcohol. If so, an inaccurate reading will be produced. Remember, do not perform a blood pressure reading on an arm with an AV shunt or fistula or on the same side of a mastectomy. Patient's position. The patient should sit in a chair, feet flat on the ground, legs uncrossed, with back supported and without talking for at least 5 minutes before the blood pressure is measured. Roll up the sleeve so the blood pressure cuff rests on bare skin at least 1 inch above the vent of the elbow. If the sleeve is too tight, ask the patient to slip the arm out of the sleeve. Have the patient to straighten the arm with the palm up and apply the proper size cuff of the sphygmomanometer over the brachial artery. Cuffs are marked to ensure the index marker is over the artery. Hold the edge of the cuff in place as you wrap the remainder of the cuff tightly around the arm. The patient's arm should be supported and the cuff at heart level. If the patient's arm is dangling or resting in their lap, the BP reading will be inaccurate. Ensure the manometer is at eye level for a more accurate reading. On the same arm where you place the BP cuff, palpate the arm at the antecubital fossa to locate the strongest pulse sounds and place the bell of the stethoscope over the brachial artery at this location. The stethoscope tubing should hang freely and not touching the patient or any object during the reading. Close the thumb screw by turning clockwise with the dominant hand on the hand valve so no air leaks out. Remember, do not close it so tightly that you will have difficulty reopening it with one hand. Pump the cuff to the point where the brachial pulse is no longer heard. This is usually 20 to 30 millimeters of mercury above the patient's regular normal BP reading. Slowly, turn the thumb screw counterclockwise with your dominant hand, allowing the pressure to slowly and evenly fall 2 to 3 millimeters of mercury at a time. Listen for the point at which the first bump sound is heard. Take note where this occurred on the manometer. This is the systolic pressure. Slowly, continue to allow the cuff to deflate. The sound will change from loud to murmur and then fade away. Take note where no sound or bump is here on the stethoscope. This is the diastolic pressure. Finally, open the thumb screw all the way to release the air and deflate the cuff completely. If you are unsure about the BP reading, wait 2 to 5 minutes before attempting to take a second reading. Blood stasis, which is the slowing or pooling of the blood, may have occurred, resulting in an inaccurate reading and discomfort for the patient. After the reading, remove the cuff from the patient's arm. Tell the patient the blood pressure reading. Remember, patients like to know. Clean the earpieces, diaphragm, and bell of the stethoscope with an alcohol wipe. Perform hand hygiene and document accurately the patient's blood pressure into the patient's medical record, including cuff's position, size, site, and reading results. Blood pressure procedure errors. Can you spot the 7 mistakes? Number 1. The patient is talking. Number 2. The manometer is not at eye level. Number 3. The blood pressure is taken over clothing. Number 4. The patient is drinking coffee. Number 5. The patient's legs are crossed. Number 6. The patient's feet are not flat on the ground. Number 7. The patient has been smoking. Blood pressure procedure common errors. Improper cuff size. The cuff bladder should be 20% wider than the diameter of the extremity where the cuff is placed. To manually assess the size, place 2 fingers under the cuff. Remember to use large cuffs for obese patients and pediatric cuffs for children and infants. Number 2. Failure to reach pressure necessary to occlude brachial pulse so that no sound is heard through the stethoscope. Number 3. Failure to deflate the cuff completely before beginning the procedure. Number 4. The cuff is either too loose, not at heart level, or not centered over the brachial artery due to failure to secure it or improperly applying it. Number 5. Cuff can't be secured because the Velcro part doesn't hold. Number 6. Air leaks in the cuff bladder or along the tubing may result in delay inflation rate or false high readings. Number 7. Valve on valve is not completely closed before beginning to pump air into the cuff. Number 8. Patient's arm is not supported or uncovered. The reading is done through clothing. Number 9. Failure to locate the brachial pulse before placing the stethoscope in position. Number 11. A stethoscope tubing or chest piece touches the blood pressure cuff while taking the blood pressure reading. Number 12. A staff is far away from the manometer to be able to accurately read it. Number 13. Too rapid deflation to accurately determine the sounds. Number 14. Failure to wait before taking a second reading. Pulse. Pulse is the number of times the heart beats per minute. The normal pulse rate varies according to the patient's age. Before the reading, perform hand hygiene. Greet and identify the patient and explain the procedure. Ask the patient if within the past 30 minutes they have smoked cigarettes or marijuana, exercise, drunk coffee or alcohol. If so, an inaccurate reading will be produced. Ask the patient to sit down and place the arm in a comfortable supported position. The hand should be at or below chest level with the palm facing up. Using your middle and index finger, apply enough pressure to feel the radial pulse. Be cautious. Pressing too hard may collapse the artery and interrupt the pulse. Start counting pulse beats when the second hand on the watch is at 3, 6, 9, or 12. Count the pulse for 1 full minute or 30 seconds and then multiply by 2. For infant patients, the pulse must be taken using the brachial artery or by apical auscultation. Brachial pulse. Take the infant's hand closest to you and lift his hand toward his ear as if you're going to put his thumb in his ear. While holding the infant's arm, gently place your middle and ring finger over the brachial artery. The area is located between the elbow and the armpit. Count the pulse for a full minute or 30 seconds and then multiply by 2. For pediatric and adult patients, you can use the apical pulse. Place the stethoscope at the apex of the heart, which is located at the fourth intercostal space. At this position, the heart is closest to the outside of the body and is heard the clearest. Listen to the loop-doop sound. Record the pulse rate and rhythm in the patient's medical record. At the end, perform hand hygiene. Respiration rate is the number of breaths a person takes per minute. The normal rate for a healthy adult ranges between 12 to 16 breaths per minute. Before the procedure, perform hand hygiene. Greet, identify, and assist the patient into a comfortable position. Place your hand on the patient's wrist and over the patient's chest and back. Count each breathing cycle, observing or feeling the rise and fall of the chest, back, or upper abdomen. Start counting when the second hand on the watch is at 3, 6, 9, or 12. Count for 1 full minute or 30 seconds and then multiply by 2. If the rate is atypical or unusual in any way, count the respiration again for another full minute. Record the respiration rate in the EHR. Note abnormalities in rate, rhythm, and depth. At the end, perform hand hygiene. Temperature. There are 5 basic routes to take a temperature: oral, axillary, rectal, tympanic, or temporal. Before the procedure, perform hand hygiene. Greet, identify, and assist the patient into a comfortable position. Ask the patient if within the past 20 minutes they have smoked cigarettes, eat cold or hot food, drink cold or hot beverages. If so, an inaccurate reading will be produced. Oral temperature. Assemble the equipment and use the blue color probe. Make sure the thermometer is set to work for oral temperature. Insert the thermometer probe into the disposable tip probe cover from the box. Secure it to cover the probe completely. Insert the thermometer into the patient's mouth in the rear sublingual pocket, under the tongue on either side of the frenulum linguae. Instruct the patient to close the mouth, forming a tight seal around the thermometer. Urge the patient to avoid breathing through the mouth or speaking. When the temperature signal is seen or heard, remove the thermometer from the patient's mouth and read the results displayed on the LED window. Dispose of the probe cover in a waste container. Return the thermometer to the storage place. Perform hand hygiene and document the results. Rectal temperature. For pediatric patients, don a pair of gloves. Assemble the equipment and use the red color probe. Make sure the thermometer is set to work for rectal temperature. Insert the thermometer probe into the disposable tip prober cover from the box. Secure it to cover the probe completely. Dip the tip of the probe in lubricant. Lay the patient belly down or slightly on the side to expose the anal canal. Gently insert the lubricated probe to 1.5 centimeters or less for infants. Helpful tip. The notch at the tip of the probe is 1.5 centimeters. If any resistance is felt, don't force the thermometer and discontinue the procedure. Otherwise, hold the thermometer still and in place until the result is signaled. After the procedure, gently withdraw the thermometer and dispose the probe cover. Wipe the anus from front to back to remove any excess lubricant. Return the thermometer to the storage place. Perform hand hygiene and document the results. Tympanic temperature. Remove the thermometer from its base. Attach a disposable probe cover to the earpiece. Gently insert the plastic cover tip of the probe into the patient's ear canal. Position. For adults, with one hand, gently pull upward and out on the patient's outer ear. For an infant or child, with one hand, gently pull back and downward on the patient's outer ear. Activate the thermometer by pressing the scan button. Observe the temperature reading in the display window. Gently withdraw the thermometer from the ear canal. Dispose of the use-proof cover into the waste container by pressing the eject button. Return the thermometer to the storage place. Perform hand hygiene and document the results. Temporal temperature. Before the procedure, expose the entire forehead by removing the patient's hair or any headwear to allow the forehead to come to room temperature before the procedure. If the patient is sweaty, dry his or her forehead. Remember, diaphoresis may cause false low readings. Disinfect the probe by gently wiping it with an alcohol swab. Procedure. Place the probe flash on the center of the forehead and press the button. Keep the button pressed and slowly slide the probe at the midline across the forehead to one side of the head toward the hairline, staying along the temporal artery. Do not go down on the patient's face. Lift the probe from the forehead and touch it momentarily in the neck just behind the earlobe to take into account any cooling on the forehead from diaphoresis. Release the button and read the temperature. Perform hand hygiene and document the results. Height and weight. Before the procedure, perform hand hygiene. Greet, identify, and explain the procedure to the patient or guardian. Instruct the patient to remove shoes or to set aside heavy objects such as keys, phones, or purses. Set all the weights to 0. The balance bar pointer should float in the center of the frame. If the balance is digital, the LED screen should stay at 0.00. Place a paper towel on the scale if the patient is in bare feet. Assist the patient onto the scale. Weight. Ask the patient to stand still while the weight is being obtained. For regular scales, move the large weight into the groove closest to the weight you estimate for the patient. If the balance bar pointer touches the bottom of the bar, then move the large weight to the left one notch. Then, move the small weight by tapping it gently until it reaches the point in which the pointer floats in the center of the frame. For digital scales, read the LED screen for the patient's weight. Leave the weights in place as you proceed to obtain the patient's height. Height. Ask the patient to place his back to the scale standing erect and looking straight ahead. The patient's heels, buttocks, and back of the head should be touching the scale. Raise the high bar in a collapsed position, making sure the tip is over the patient's head. Open the bar into the horizontal position and bring it down gently to touch the top of the patient's head. Leave this setting in place and assist the patient in stepping off the scale. Calculate the patient's weight by adding the numbers at the large and small weight groove markings to record the weight. For LED scales, read the digital screen for the weight. Read the height as marked behind the movable level of the ruled bar. Return the weights to 0 and the high bar to the normal position and discard the paper towel. Record the readings in the patient's chart. Pain assessment. To make a correct diagnosis, it is important to evaluate the quantity, affective, and cognitive aspects and other characteristics related to pain. Remember, the pain level is subjective, and it is what the patient reports it is. Pain evaluation is more difficult the younger or less verbally communicative the patient is. Hence, the clinical staff may use the 1 Baker Faces pain scale to assist in the assessment. We also know that visceral and chronic pain is more difficult to evaluate than somatic and acute pain. Pain evaluation should include an accurate description of the pain location and quality. To do so, the clinical staff may rely on tools that include body diagrams, scales, and quality measures. At the end, document accurately the complete pain assessment in the patient's EHR. Measuring head circumference for pediatric patients. Remember to use a measuring tape that cannot be stretched. Securely wrap the tape around the widest possible circumference of the patient's head. This is above the eyebrow, above the ears, and above the most prominent part of the back of the head. Take the measurement 3 times and select the largest measurement to the nearest 0.1 centimeter. Remember, head circumference measurements are key to assess appropriate development in babies. Fingerstick principles. Start with the cuvette holder in its loading position. The display will show 3 flashing dashes and the HemoQ symbol. Make sure the patient's hand is warm and relaxed, and don the appropriate PPE. Use only the middle or ring finger for sampling. Remember, avoid fingers with rings on. Clean the finger with alcohol and allow to air dry. Don't blow on it or fan it. Using the thumb, lightly press the finger from the top of the knuckle towards the tip. This will help to stimulate blood flow. For best blood flow and least pain, take the sample at the side of the fingertip. Don't use the center of the fingertip. Fingerstick procedure. While applying light pressure towards the fingertip, puncture the finger using a lancet. Wipe away the first 2 or 3 drops of blood. Reapply light pressure towards the fingertip until another drop of blood appears. When the blood drop is large enough, fill the microcuvette in one continuous process. Remember, do not refill. You have completed your training. Thank you.